Okay, so today we are talking about neurodevelopmental disorders. And as you may recall from the first day of class, I mentioned, I don't even remember, that these are what used to be considered the disorders of childhood, or the actual terminology in DSM-4TR was disorders first diagnosed in infancy, childhood, and adolescence. That was quite a mouthful, and instead they've renamed them the neurodevelopmental disorders, which I think in a lot of ways is a more accurate name anyway, because it certainly has the developmental component, so we know it affects development, and then also the neuro component, because a lot of these in fact do have significant brain and neuro components to them. So as I know I mentioned this on the first day of class, and it's also I think on your course outline, normally this lecture would actually span over 2 classes. So this is probably going to be one of the longer ones. But again, it would span over 2 classes with a 70-minute video thrown in, which I will not be showing you on this video. You will watch on your own. And also with plenty of time for discussion. So hopefully this won't be too long and arduous, but I make no promises. We'll see what happens, okay? So the first thing we need to consider, and that we really, really need to consider, is we always have to consider the age and developmental level before classifying a child's behavior as abnormal. So we've talked before with other disorders about the importance of societal context, of cultural context, and that's important too. I don't want you to forget that and just toss that out. But with children, it's really, really important that we think about how old are they and where are they in terms of their development? Because if they're not on the typical development trajectory, then things that may be normal at a younger age might still be normal for them at an older age. And similarly, there are things that are normal at some ages that are abnormal at other ages. So that's one of the things that we really have to think about. So if we take just a really simple thing, fear of the dark. Young children often have a very healthy fear of the dark. Parents have to check under the bed and in the closets for boogeymen and monsters, and they need a nightlight, or they need the hallway light left on and their bedroom door left open. And darkness is something that is really scary to children because they don't know what happens in the night, right? They're sleeping, they hear noises, so they want to have a light on. Now, at this point in your life, so in your 20s, 30s, something like that, presumably most of you do not sleep with a nightlight on anymore, right? Or insist on having a light on. Some of you do, and that's okay. I'm not here to judge. I'm not here to say that that's abnormal. That just might be something that you've gotten used to, and it's more of a habit than a fear. But young children will be terrified and will cry and will scream and will fuss if you don't turn on a light if they have a fear of the dark. If you were to do that today, that might start bordering. So again, I'll remind you, as I have throughout the term, in Blackboard on the contacts list, there's information about counseling. And also, as I would typically say in class, never again in your life will you have an opportunity to have counseling without paying for it, most likely. So if you've got anything going on, shoot an email over to counseling or give them a call and set yourself up with one of our fabulous on-campus counselors. Okay, another piece, and this one is way funnier when I actually have students in class, but we're going to see what I can do to Ian and see if I can get him to crack up. I might be able to. So another thing that we have to consider, again, age and developmental level, another example is bedwetting. So bedwetting is something that is quite common in young children, right? So preschool age children, even early elementary school children, I mean, we expect so much of them, right? Like they have to learn when they're like 2 or 3 how to not go to the bathroom in their pants, which is all they've been doing up to that point in diapers. And then we expect them to know that they have to wake up to go to the bathroom when they're like dead asleep because they've had a busy day playing, and it doesn't always work. So they wet the bed. And the DSM says, don't worry about it until the child is older than 5 or 6. And then if it's happening frequently and it's causing distress and there's no medical reason, then maybe in fact it's a diagnosis called enuresis. But one of the things that I learned several years ago, so the university I worked at before coming to MRU was a small liberal arts university in upstate New York. A lot of our students lived on campus, and there tended to be some pretty informal relationships between professors and students. I'm not talking inappropriate stuff, but I'm just saying, like, students used to come hang out in my office a lot. They would just come, they'd chat, especially my advisees. And so this one particular student, who I will not name, because that would be wrong and bad, he was on one of the sports teams on campus. And a sports team that is known for partying and for drinking quite a lot. And one day, he came to my office missing an eyebrow. Because he had had so much to drink, he passed out and someone shaved his eyebrow off. And I was like, oh man, okay. We sort of talked about it a little bit, but I was like, whatever, I'm not your mom. And then another time, he told me about someone had like wet the bed. And I was like, what? Like what? Like you're college students, like what? And apparently within this team, and as I then talked about it with my classes, I found out it's actually a fairly normal, I don't want to call it normal, but it seemed pretty normal that like a lot of my students knew someone who had gotten so drunk that they just wet the bed because they were too drunk to get up and go to the bathroom. And I was like, huh? Like that's a thing? Apparently I missed that phase in college. So again, considering the age and developmental level, a university student who is now wetting the bed, the first thing I'd probably do is an alcohol use assessment. Before jumping to this is like a bedwetting problem, I'd be like, let's talk about your drinking, right? So those are some of the things that we have to consider. And I kind of succeeded. Ian's cracking up a little bit. So I feel good about that. Again, I hope none of you ever have to have this experience of teaching to a largely empty room. It's very weird. It's kind of fun, but kind of weird. Okay, the other thing we have to keep in mind is that some disorders are unique to children, others begin in childhood and can last through adulthood. So a lot of times with kids, we tend to think like, oh, they'll just grow out of it. Yeah, with mental health disorders, that is not often the case. So a child who experiences depression in childhood will likely be someone who experiences depressive episodes in adolescence and into adulthood. A child who is anxious will likely continue to be anxious. Now, they might learn things along the way that help them manage their anxiety. They might learn how to recognize that their anxiety is getting too high. They might have tips and tricks and meditation and exercise and herbal teas and who knows what else to help them manage it. They may know when they need that extra little bit of help to consult a psychologist or even use medication, but they'll still have anxiety as they grow up. For a lot of years, it was thought that with ADHD, children would just outgrow it. We know that that is not the case. We know for some kids that is the case, but we also know for some it continues to be a problem into adulthood. So we want to just be mindful of that as well as we progress. Now, the next slide is just, it doesn't matter. You're sitting here watching this at home or wherever I don't know, on a C-train or something. You don't need to, though, take note, per se, of the next slide because it's just an overview slide. So these are the disorders that we are thinking about and that we're going to be covering briefly today. So this is another place to say that a lot of students end up taking 4485, so this advanced abnormal class, and 4451, which is the atypical child development class. If you are in both classes simultaneously, why do you want to be seeing me for 6 hours a week? I don't know. That's your own issue. That might be a mental health diagnosis in and of itself. However, the way we cover the neurodevelopmental disorders in this class is way less detailed than we cover it in 4451. So just keep that in mind, particularly for things like assignments or exams, that there might be some small differences, but also the level of detail. You're not expected to know a 4451 level of detail for 4485, okay? So we'll talk about ADHD, we'll talk about specific learning disorder, we'll talk about autism spectrum, and we'll talk about intellectual disability, okay? This is a smaller list than what used to appear in the DSM. So this is all DSM-5. In DSM-4-TR, there were actually quite a few more diagnoses in that chapter of disorders first diagnosed in infancy, childhood, and adolescence. But there were some like mergers and acquisitions, if you will, and different things got collapsed in together. So autism spectrum used to be separate diagnoses of autistic disorder, Asperger's syndrome, pervasive developmental disorder, childhood disintegrative disorder. Now that's all considered autism spectrum disorder. Intellectual disability used to be on axis 2 of the DSM. There's no longer 5 axes of the DSM, it's just the diagnoses. So that's also been moved just to the regular diagnostic realm. So just a couple of things, and then other disorders, conduct disorder and oppositional defiant disorder are now in the disruptive impulse control and conduct disorder category, with intermittent explosive disorder, pyromania, antisocial personality disorder, and kleptomania. So again, a little bit of moving and shaking happened with these different diagnoses. But let's start with ADHD. So you'll find the diagnostic criteria in the text, table 14.1, page 483. And what I really want to highlight, I'm not going to sit here and go through all the symptoms with you, is that a child has to be exhibiting a minimum of 6 symptoms of inattention and or 6 symptoms of hyperactivity and impulsivity in order to be diagnosed, okay? And you might be thinking, Carrie, why 6? Like, a child who has 5 symptoms of hyperactivity, is that normal? And I would say, well, normal is a tricky thing. And the reason why 6, it's not like the makers of the DSM sit around a conference table and everybody just throws numbers into the middle and someone grabs one and goes, 6, we have a winner, 6, we will have 6 symptoms. This is all based on clinical data. So what they have determined is that a child with 5 symptoms of hyperactivity and impulsivity is clinically different than a child with 6 symptoms. And that's why 6 has been set as the cutoff, the bare minimum. A lot of children will have more symptoms. Now, you also might be thinking, okay, hang on a second. But what if they have like 4 symptoms of inattention and 5 symptoms of hyperactivity and impulsivity? What do we diagnose them with? And I would say, not ADHD. And you're thinking, well, huh? How is that possible that a child with 9 symptoms total doesn't get a diagnosis? And I'll say, you have stumbled upon one of the flaws of the ADHD diagnostic system, okay? They will get a diagnosis, it just won't be as clear a diagnosis. And hang on a second, we'll get there, okay? I know, you're like, whoa, big, that's sort of mind-melding information. But we'll get there. Another big change in DSM-5 is that the symptoms have to be present prior to the age of 12. It used to be that symptoms had to be present by the age of 7, and now they've changed it. Now, DSM-5 also allows for the diagnosis of ADHD in adolescents and adults. And in fact, if someone is over the age of 17, they only have to have 5 symptoms of inattention or 5 of hyperactivity, impulsivity. The reason we say symptoms present prior to the age of 12 is because we recognize, again, different schools, different types of learning, different home life scenarios will potentially mask symptoms. So parents don't always know. So Bob and Sue have a little boy, Johnny, and Johnny seems to be pretty darn active. He has a really hard time settling down. He's always on the go. He's always fidgeting. He's always doing it. He basically meets at least 6 symptoms of hyperactivity and impulsivity. But Bob and Sue have never had any kids before, and they haven't had a whole lot of experience with kids. They're both the oldest in their families. They don't have any nieces or nephews yet. They're the first of their friend group to have kids, so they just go, well, Johnny's a really active little boy, right? They're not having any other trouble with him, so they dismiss it. And Johnny goes to school, and they won the lottery somehow. They got the teacher who's the one who is so patient and so good with rambunctious little boys that she never says that there's a problem, because she's of the mindset boys will be boys. It's really hard for 6-year-old boys to sit in school all day. That's okay. I'm just going to give Johnny extra recess time, because I find if he runs 10 extra laps around the schoolyard, he's able to settle down. Okay? So now Johnny's turning 7, he's going into grade 2, And what do you know? He has the same teacher from grade 1 because she moved up with her kids. So all of a sudden, Johnny makes it through elementary school and nobody has ever uttered the terms ADHD because there have been enough strategies and there have been enough supports in place that his behavior has never reached that level of disability or distress. But now Johnny's done with elementary school. Now he's going to junior high. And now's when the shit hits the fan. And Johnny's teachers are like, what? Who is this child? How did this happen? I go, oh, yeah, okay, well, the symptoms have been there the whole time. They were clearly there, but they weren't diagnosed. DSM-5 was like, no, it has to be there by age 7, and it has to be documented, and it has to be noted, and a lot of people were getting lost in the shuffle. So we'll go back and look at Johnny's history and be like, oh my God, those symptoms have been there since the age of 2. But they also didn't sort of max him out. He was able to rein it in with enough support, with enough help, that it wasn't causing impairment. But now the demands of his situation are exceeding what he's capable of. The symptoms are becoming more prominent. We're seeing it more prominently. We're diagnosing him. So I want you to understand that it's not that it just appears at age 12. It was there. We just didn't know it. We weren't calling it ADHD. Hopefully that kind of makes sense. Another critical piece is that the symptoms have to present in 2 or more settings. A child with ADHD has ADHD whether they're at school, whether they're at hockey, whether they're at home trying to do homework, or whether they're at home trying to play the game of life with their family, right? They're impulsive, they have trouble taking their turn, they're blurting out answers to other people's questions, they're not listening to their coach, they're doing the last drill when the team has moved on to the next drill because they weren't paying attention because they thought they saw the Zamboni driver heading to the Zamboni, and that means ice time's almost done and the Zamboni's gonna come out and that's so cool. And like their team's off the ice in the locker room already and they're still standing at the blue line. Okay? That's ADHD. The child who only struggles in school but who does great in all other domains is the child who just doesn't like school and is acting out because that's what kids do. So we have to remember this present in 2 or more settings is really important as well. Okay? So for diagnosing ADHD, we often will get a parent's perspective, a teacher's perspective, and then as well, if they're involved in sport or some other activity or they have a babysitter who they have a lot, get that person's perspective because we have to be clear that it's actually happening in more than one place. And then that last bit, symptoms interfere with functioning. We have to remember that that's a problem too. So remember, little Johnny, until he got to junior high, he was fine because teachers were helping, parents were helping. They were just dismissing him as really energetic. It wasn't getting in his way. But he got to junior high and he couldn't cope anymore with what the demands were. The ADHD is interfering with his functioning. Okay? So, one of the things that we do is we diagnose ADHD as either combined type, predominantly inattentive, or predominantly hyperactive impulsive. So predominantly hyperactive impulsive means they have at least 6 symptoms of hyperactivity, impulsivity, and fewer than 6 symptoms of inattention. So they can have 1, they can have 4, they can have none of inattention, but they have at least 6 of hyperactivity, impulsivity. Same is true for predominantly inattentive. They have at least 6 symptoms of inattention, and then they have any number of symptoms of hyperactivity, impulsivity up to 6. So they can have 0, they can have 2, they can have 5. If they have at least 6 symptoms of inattention and at least 6 symptoms of hyperactivity, impulsivity, then they're combined type. Okay? So to be diagnosed with ADHD combined type, the child has to be exhibiting at least 12 symptoms of ADHD. And so this is where I was saying before, we get into that little bit of a problem because if a child has 9 symptoms of ADHD, but 4 are inattentive and 5 are hyperactive impulsive, does that mean the child does not have a clinical problem? No, they still have a clinical problem. And we just use that, what used to be the not otherwise specified category, So it's basically ADHD, like other, or not otherwise specified. The problem with that is it tells us that the child has ADHD, but it doesn't tell us which are their predominant symptoms, because the treatment for inattentiveness is going to be different than the treatment for impulsivity, right? A child who isn't capable of paying attention is different than a child who's impulsive. So we attack it a little bit differently. So we always still have that ADHD NOS category, the not otherwise specified, but it doesn't give us as much information. So the child with 9 symptoms, and likewise, a child with 5 symptoms of hyperactivity, impulsivity, but where it is causing impairment in school, it's causing impairment at sports or at home, they also could still get a diagnosis of ADHD not otherwise specified. They just would not get the predominantly hyperactive, impulsive label with it. So hopefully that makes sense. But of course, it is a little bit problematic because you're thinking like, really, 12 symptoms? But yeah, really, 12 symptoms. Just a couple little statistics. About 6% of school-age children have a formal diagnosis of ADHD. I'm never sure if this number is too high or too low or just right, because I suspect there are a lot of children who do not have a proper formal diagnosis of ADHD but are being treated as if they have ADHD. I also imagine there are a lot of children who have been told they have ADHD and who are being treated for ADHD who do not in fact have ADHD. We seem to have hit a point in our society where ADHD became like, well, if you're having trouble in school, you have ADHD. And teachers who are very, very well-meaning and who are definitely not given enough tools to do the jobs they're expected to do are diagnosing ADHD. A teacher is not a diagnostician unless they also happen to be a psychologist and they're choosing to teach at the elementary, junior high, or high school level. But what happens is, Mrs. Smith has been teaching elementary school for a long time, and she has seen a lot of kids coming through her 3rd and 4th grade classes who end up getting diagnosed with ADHD. So she now has little Sam, and Sam is looking to her like a classic case of ADHD. So she calls up Sam's parents, or actually today sends an email to Sam's parents and says, you know, this is what I'm seeing in class. These are the behaviors Sam is exhibiting. I've seen a lot of kids similar to Sam in the past, and they've all ended up being diagnosed with ADHD. You might want to consult with Sam's doctor or a psychologist because I think that might be what's happening. So parents get that, and they think, okay, well, yeah, he's a little hyperactive, or yeah, he's a little impulsive, or yeah, he has trouble paying attention to stuff, but you know, we've never really thought of it as a problem, but if Mrs. Smith is saying it's a problem, maybe it is a problem. And so then they think about it, okay, psychologist, that's going to be at least $200 just for the initial meeting, let alone any assessment and treatment, or family doctor, 10-minute visit, covered by Alberta Health. Well, which one are you going to choose? Pick psychologist, pick psychologist. No, you're going to choose the family doctor because it's easier and cheaper, right? And I'm not saying that parents make all their decisions based on finances and time, but let's face it, the teacher pretty much said he's a classic case. Why do we need to go through all this expensive testing and assessment? And, you know, the kid doesn't want to do it. And so then family doctors are faced with having 10 minutes to assess whether a child has ADHD. Guess what? They can't. They really can't in that time frame do the same type of job that a psychologist would do assessing for ADHD. But they get out their ADHD checklist, they ask the parents and Sam if these are the symptoms he's having. He says yes, makes sure that Sam is healthy enough and doesn't seem to have any cardiovascular issues, and says, okay, well, let's start Sam on some Ritalin and see what happens. Ritalin is one of many ADHD medications. It was the first one, though, that was like approved for use in children. It tends to be fairly popular, even though there's some fancy other stuff out there. But it's a stimulant. And we never really want to diagnose something based on response to medication. Because if I gave everyone in this room right now, okay, wait, that's just Ian and me, But if we each took some Ritalin right now, wait, let me just go grab some. No, I'm kidding. I don't have any. But we would both find it easier to pay attention, right? We're heading into that like after lunch lull right now, that sort of quiet time where you just want to sip some tea or read a book. But like we got to push through. If we each took some Ritalin, we'd be more focused. We'd be more attentive. Does that mean we both have ADHD? Of course not, right? So response to medication isn't a great way to diagnose. We want to diagnose based on symptoms, not on response to treatment. But that's what happens a lot. So is this 6% inflated? Maybe. Is it under? Like, is it underflated, deflated? Maybe, because there's still stigma attached to ADHD. So I don't really know. What I do know is that we're not doing diagnosis and assessment the way we really should, in large part because we don't have the time or the funding for it, right? And that's a real travesty. But then again, there are so many cuts to education and budgets in so many different ways. How on earth are we going to advocate for this to be added? Good luck. But you guys are the future. You can change the way these things are moving forward, or at least try for it. I mean, we're still trying for it, but it's not happening. We do see that ADHD is diagnosed in boys as a rate of 4 boys to every 1 girl diagnosed with ADHD. Again, I question the accuracy of this. Schools are basically, and especially elementary schools, are designed for girls to thrive. There's a lot of sitting quietly in your place, a lot of raising your hand, a lot of verbal skills, which are all things that girls typically are better at than boys, right? Young children probably should not be sitting at a desk for 6 hours a day, but in a lot of places they are. Boys get antsier. They start fidgeting more. They can't handle it. They get diagnosed with ADHD, right? So is it fully accurate? I don't know. We do know that there are some brain structures that can be a little bit slower to develop in some boys, particularly in the frontal lobe, which is in charge of executive functioning, which are basically the things that we're looking at with ADHD, sequencing, turn-taking, right? All those sorts of things. So some boys, when their brain finishes developing, they actually outgrow ADHD. And that we have seen with imaging studies. But is that the vast majority of them? No. Because we also know that 68% of children with ADHD continue to have problems through adulthood. So we know that not everybody's growing out of it. We know that boys are diagnosed at a much higher rate. And we know that about 6% of school-age children will carry the diagnosis. Okay, so how do we treat it? Well, I hate that I'm doing this as the frontline treatment, but let's face it, the easier treatment is biological, and we're talking meds here. So stimulant medication like Ritalin, Concerta, Adderall, those are all used. Children typically will take it on school days. They'll often take breaks in the summer when there's less tax on them for paying attention. But if you have a child with ADHD who's involved in like high-level sport, they may actually need to use the medication on weekends and summer breaks and things like that if they're engaged in their sport, because that same problem they have, listening to directions, waiting their turn, following the play, might still be occurring, and they might need the medication in order to be okay. Most of the major leagues, if you have a documented case of ADHD, will permit some medication use. They will still ban some because stimulants can be performance enhancers as well. That's just a little tidbit from Carrie, the sports psychologist, not Carrie, the clinical psychologist teaching about neurodevelopmental disorders. In addition, there are some antidepressant medications that seem to have an effect on ADHD, particularly bupropion, which is also better known by its trade name of Wellbutrin, and imipramine, which is an older tricyclic antidepressant. We know that antidepressants, by and large, work with serotonin, and also these ones to some extent with norepinephrine. Norepinephrine is our internal stimulant, so it kind of makes sense that if we're using a stimulant medication, using another medication that targets norepinephrine could be successful as well, okay? And then also an antihypertensive medication, so this would be for people who have high blood pressure to bring their blood pressure down, clonidine seems to help as well. It regulates the norepinephrine release in our body through the locus coeruleus. So again, working on the norepinephrine system is really going to be a key part of medication as the treatment for ADHD. Now, just because medication seems to be the easier, quicker, more cost-effective route doesn't mean it's the better route. It doesn't mean it's the worst route. I want to be clear about that. There's a time and place for medication. There always is. My gut tells me that we are over-medicating today's youth because it's easier, right? But there are some children that even with all the behavioral intervention in the world would still need medication. I feel, though, that we've gone to this place of let's use medication first, and then if that's not working or that's not enough, let's add in the psychology component, as opposed to, hey, let's try behavior modification first and then turn to medication if that doesn't work. And so that takes us to the psychosocial interventions, which tend to be behavioral in nature. So we do a lot of behavior modification type stuff, particularly reinforcement for on-task behavior, right? We want children to believe that they can do what we need them to do. We want them to have confidence in that, to feel good about it, to keep practicing it. And we're also going to do some parent training. Parents do the best with what they have, but sometimes don't have all that much to work with, okay? So parents oftentimes end up reinforcing behavior that they shouldn't be reinforcing, but they don't know that they shouldn't be reinforcing it. So again, let's take Sam, our little boy with ADHD, and he really loves climbing trees in the backyard. Sam has fallen out of several trees in the backyard. Let's put it this way, the orthopedic folks at the Children's know Sam very well at this point, okay? There have been broken arms, broken shoulders, broken legs. So logically, we would think that when Sam says, hey, I'm going to go climb the tree in the backyard, his parents might say, not such a good idea. The problem is they're now paying attention to Sam, which maybe they hadn't been before. So Sam might be continuing to do something that is risky and potentially harmful because that's what gets his parents' attention, right? And he's not learning from having fallen and broken so many things, because also, guess what? When you're a kid with a broken leg, guess what you get from your parents? Attention, right? So Sam is figuring out all these ways to get his parents' attention, but they're not good ways. So parent training would work on helping the parents understand how to respond to Sam's needs in a way that don't involve trips to Children's to get casted. Okay. That's it for ADHD. So that means it's time for a reflection question. And this one is tricky to answer in only one paragraph, but I know you guys can do it. I have faith. Do you think ADHD is a real disorder or not? Explain it. And then when you're done, come back. Okay, so you've reflected, you've answered. Let's talk about specific learning disorders. A specific learning disorder is diagnosed when a child has performance that is substantially below what would be expected given the person's age, IQ, and education. Okay, you can find the diagnostic criteria in your text, table 14.2, page 490. And I don't want to spend a whole lot of time on this, in part because you're going to watch a video in a few minutes, or well, maybe you won't watch it in a few minutes, maybe you'll watch it tomorrow, but you're going to watch a video that is going to do a really good job of explaining learning disorders, although using the other term that we sometimes use of learning disability. So learning disorder is the technical term in DSM-5. However, previously we've used the term learning disability, and that's still used quite a bit to describe it. There are 3 types of learning disorders: disorders of reading, disorders of written expression, and disorders in mathematics. So when someone says they have a learning disability, we need to know the rest of that sentence. Which disorder is it that they have specifically? Because academic tools or other tools to be more successful with a disorder in mathematics are going to be different than the tools for a disorder in reading. So it's really important that we know where the specific disorder is. People can have more than one disorder. And one of the really key things to remember about people with learning disorders is a learning disorder has nothing to do with a person's intelligence level. a person can have an IQ or an intelligence quotient that puts them in the gifted range, but still have a disorder in mathematics. So one of the things that often happens amongst children is children always find out who the kids in their class are who have learning disorders because those kids leave class or have extra time for tests or whatever. And then kids will often say, oh, you're stupid. They're not. And in fact, they may be quite a bit smarter than you, right? Children with learning disorders have IQs that span the whole IQ spectrum. But they have a disorder with processing, with understanding, whether it's reading, written expression, or math. It has nothing to do with intelligence. And that's going to be a point that's made time and again in the video that you're going to watch in just a few minutes. In terms of some statistics, so this one's kind of always surprising to me. About 12% of children have learning disorders. Yet, so just keep in mind, a few minutes ago I said about 6% of children have ADHD. How much more do we hear about ADHD? How much more emphasis is there in our general society on ADHD? How much funding goes to ADHD versus the 12% of children with learning disabilities? If a child has an undiagnosed learning disorder and they're not receiving the supports that would help them succeed in school, we are setting that child up for long-term failure. The supports that children get for learning disorders, they aren't an edge, they aren't an advantage, they're leveling the playing field. If I can open up this textbook and read it and understand it and retain it, great. But if you open it up and the words are all scrambled on the page for you, and so you need this book put into an audio recording, and then when you listen to it, you can understand it just fine, understand it and retain it, then that's what you need to level the playing field. The services and accommodations that children with learning disorders get are not an advantage. It's just making things even for them. We spend a lot more time thinking about ADHD. Why? It's more disruptive in the classroom. 3 children with undiagnosed learning disorders are not a pain in the ass to the teacher. 1 child with undiagnosed ADHD is, right? That 1 child with ADHD who's always off task, always out of their seat, always making mistakes, always interrupting, is taking up a lot of the teacher's time. The child who can't read at grade level, or the child who can't do math, even though it's been taught to them, is just getting low marks, but isn't troublesome for the teacher. So we have to be careful and remember that. Statistics are what we should be making these decisions based on, not how annoying a child is. Okay? Okay, some related disorders, which again, I'm not really going to spend time on. These tend to be the domain of speech-language pathologists. We have childhood onset fluency disorder, also known as stuttering, language disorder, and social or pragmatic communication disorder. These are all considered communication disorders. And also we have Tourette's disorder. And Tourette's disorder is more commonly diagnosed in children. And oftentimes children will have tics, whether they're physical or vocal tics that they can't control. And so they end up oftentimes getting in trouble for having these like outbursts or interrupting, but they can't control it. Okay, so this takes us to our video. It's about 68 minutes. It's called How Difficult Can This Be? The Fat City Workshop. You can stream it from the MRU Library website on a service called Canopy. Remember, you have to be logged in with your MRU login in order to stream from the library. If this link does not work, because it might not work, because I've had trouble with it in class sometimes, Canopy can be kind of finicky, just go to the library website, search for How Difficult Can This Be? It'll appear in the search results, and then you can just click on the link because it'll take you to the online link. Alternatively, the library has a copy on DVD that you can borrow as well. So you're going to go ahead, watch that, and then come back because there's a reflection question after the video. So reflection question number 2, how difficult was it to follow along with the video given the speaker's accent? And how could this video be made more accessible? So take a moment, think about those. I'll have some water. Okay, welcome back. And now let's talk about autism spectrum disorder. So autism spectrum disorder is an umbrella term for several different disorders. Autistic disorder, Asperger's disorder, childhood disintegrative disorder, Rett disorder, also pervasive developmental disorder, all of those. I'm going to go with the assumption that most of you are familiar with autistic disorder and Asperger's disorder. Childhood disintegrative disorder is quite rare. It's when a child will develop normally for 2 years and then start to regress and have deficits and basically get back to an infantile state. Rett disorder is found only in girls. They have normal development for a period and then it slows down, okay? All of these have been collapsed into the umbrella term of autism spectrum disorder in DSM-5. And you'll find the diagnostic criteria in your text, table 14.3, page 494. So what I'm going to do is, instead of running through all of the diagnostic criteria, which I all know you're capable of reading, we're going to just talk about what autism looks like, what it is, what the major characteristics are, okay? So the major characteristics, are impairments in social communication and social interaction. In DSM-4-TR, this was split into 2 separate categories. Social communication was one feature, social interaction was the other. Now they've been collapsed into one category, and a child has to show 3 symptoms of impairments in social communication and social interaction. And then restricted repetitive patterns of behavior, interests, or activities. And a child has to show 2 symptoms in this area. So this will be something that when we have our discussion groups, we'll talk a little bit about whether this makes sense, what some of the consequences of collapsing everything into one category it was, and whether there really are differences in social communication and social interaction, or whether they actually make sense to put together. So that's going to be some of what we talk about. So children who meet the diagnostic criteria for autism spectrum disorder are going to have impairments in how they communicate with other people, not because of an actual language deficit, but because of the ways in which they use or don't use language. And I'm talking about verbal language as well as nonverbal, so body language, social distancing. Again, there are things that are now changing. Like now we all use the term social distancing in our everyday vocabulary, and we take it to mean keeping at least 6 feet apart from another person. Of course, with autism spectrum, some children in the past would have kept 6 feet apart from other children, and we think, well, that's really weird. Today, if somebody gets too close, you're like, what are you doing? Really, back off. Why are you so close to me? That's just our new normal, or whatever. I don't like to think of any of this as normal. This is our new temporary, is how I'd prefer to think about it. And so also body language issues, eye contact issues. So the things that make communication, they're lacking, by and large. And then this restricted repetitive patterns of behavior, interests, or activities. Sometimes children with on the autism spectrum will engage in what's known as self-stimulation, where they'll engage in repetitive behaviors that they find stimulating. Sometimes it can also cause injury, though. Head banging is one of those things, where a child will bang their head against the wall. They might also have very, very restricted range of interests and activities. So they might like trains, and only trains. And you can buy them a toy truck, and they will throw it at your head because it's not a train, because they only care about trains. They can tell you everything about trains, about every train ever made, right? But that's it. That's where it ends. And same with activities. They might have 1 or 2 things that they enjoy doing, and that's what they want to do all the time. So that's part of what we're looking for the diagnosis of autism spectrum. Because it's a spectrum disorder, we're then going to go ahead and determine the level of severity. That's new to DSM-5 as well. So we either identify them as requiring support, requiring substantial support, or requiring very substantial support. So a child at level 1 who requires support might need the help of an instructional assistant in the classroom, but that's all they need, right? A child with requiring substantial support may need their own devoted instructional aid in the classroom. They may also need speech therapy, occupational therapy, other supports. They might need to have basically that instructional aid from the classroom serve as kind of like a personal shadow who's there at sports activities as well, at home with the family. Requiring very substantial support likely would be needing special education, so not able to function in a regular classroom even with an aid, as well as other supports for home life. Okay, in terms of some statistics, about 1 in 50 school-age children are diagnosed with autism spectrum disorder in the US. And one of the things here is people often wonder, are we now seeing more autism? Has autism become, the diagnosis of the hour? Well, yes and no. Yes, we are seeing more autism, but it's not because there is in fact more autism, it's that we're better at recognizing it and we're better at diagnosing it, okay? Are there other factors that have led to the increase in cases, in the incidence of autism? Absolutely. But I think the bigger component of why we're seeing more is because we have a better understanding of what it is. We're screening kids now better. They're actually doing more universal screening where physicians and like public health nurses and schools have lists of milestones that they're assessing children for. And if they're missing those, they're sending them for referral right away instead of waiting. So that is definitely a factor. Okay. This is another disorder where we see a disproportionate number of males being diagnosed. So for every female that's diagnosed with autism spectrum, 4.4 males are. So even more than ADHD. Okay, and we don't often talk about or hear a lot about the gender difference in autism spectrum, but there is one. Okay, that takes us to the end of autism spectrum disorder. We have just one more disorder before we wrap up this lecture. So we're going to just talk about intellectual disability or intellectual developmental disorder. And this is what used to be known as mental retardation. Not a terribly pleasant name, so it's been renamed to better reflect the fact that it is an intellectual disability. The term retardation has been used out of context in so many derogatory ways that they've taken that out of the diagnostic language for this. When someone is diagnosed with intellectual disability, they have significantly below average intellectual and adaptive functioning, and we look particularly at 3 domains of difficulties: conceptual, social, and practical. Okay, so conceptual, we're talking about skills deficits such as language, reasoning, knowledge, and memory. Okay, so that conceptual domain is that sort of more traditional school smart type stuff that we think about. The social domain has more to do with problems making friends and social judgment. So as young children, one of the things we often learn is don't talk to strangers, right? Stranger danger, don't talk to strangers. A child with an intellectual disability will just walk up to anyone they see and be like, "Hi, how are you? My name is this. I live here." And you're like, whoa, hold on, that's too much information. Okay, they can be very, very friendly, and that could put them into danger. And then practical has to do with the activities of daily living. So things like getting dressed, things like remembering to shut the fridge door after opening the fridge, or things like, and again, my child, I'm not saying my child has intellectual disability, but this morning we walked into the garage for me to take her to school and the car door was open because she left it open all night, and I had that moment of panic of, oh God, has the light, and the light was in the car was out, so I was like, do I have a dead battery? Am I going to be able to make it out the door? Because we were, of course, running late for school this morning. And luckily, that was not the case. Luckily, when the back door is left open, the light does not stay on. It's when a front door is open. So my battery was fine, got her to school. But I was like, why is the door open? And she's like, I forgot to close it. Right? That's pretty much how I felt as a parent. So that, though, is a one-off. That's not our everyday experience. People with intellectual disability would always need that reminder. You have to close the car door. You have to close the door when you walk into the house. You need to remember to brush your teeth. You need to remember to take a shower, right? That might be, depending on the level of severity, that might be stuff they can't do. So a big part of the diagnosis these days is looking at that adaptive functioning, particularly looking at that practical side of things. In terms of statistics, about 2% of the population will meet the criteria for intellectual disability. So again, we're not talking about a huge proportion, and 90% have what's considered mild intellectual disability. So the vast majority of people who have intellectual disability have a mild form of the disorder, which means they might need some supports, but they are likely to be okay on their own, have some degree of independence. Okay, so reflection question number 3. Given that 90% of cases of intellectual disability are considered mild, what do you think of the emphasis on screening pregnant women for abnormalities? 1 paragraph, 6 sentences. Okay, well, now that we're back from that, let's just we are wrapping up after this, okay, by talking about some of the different things that can cause intellectual disability. So one of the things to remember is that in a lot of cases, we don't know what the cause is. So even though I'm going to give you a whole slide full of causes, we often don't know specifically, right? We're still doing some best guesses, unless it's a specific genetic component, which we can test for. So the environment is a factor. Deprivation, abuse, neglect, particularly early on, right? Particularly early on in childhood, that's a factor. So infants don't need that much, but they do need to be loved. That helps them feel secure. They need to be fed, and they need to be fed properly. One of the problems that can happen with deprivation, particularly for people who are living in extreme poverty, is either that the mother will not produce enough breast milk or not enough nutritious breast milk because of what she's eating, or if she's not able to breastfeed and is using formula, she may thin out the formula by adding more and more water to it than what it's supposed to have, and then the child is not getting the nutrients and the vitamins that they need to thrive. So that could be a contributing factor. Similarly, any abuse or neglect early on can also be a factor. Prenatal factors, pretty much the 2 big things are going to be illness and drug or alcohol use. So we know that measles can be particularly bad. If a mother contracts measles while she's pregnant, the impact on the developing fetus could be intellectual disability. Same thing even with the flu. This is why it's so important for people, even if you have no intention of becoming pregnant. We know that no method of contraception short of abstaining from sexual relationships can keep you 100% safe from pregnancy. It's one of the reasons it's so important to get a flu shot every year, and why it's also important to make sure you are up to date on vaccines. All of you are of an era that you should have had 2 doses of the MMR, the measles, mumps, rubella vaccine. And then with drugs or alcohol, we can have fetal alcohol syndrome develop. So that's a distinct pattern of facial features and also intellectual disability that we see in children who were exposed to alcohol in utero. And you might be thinking, well, how much alcohol? And my answer is, I don't know. So we don't know what a safe amount of alcohol is to drink during pregnancy, and that's why the widespread advice is no alcohol is safe during pregnancy, because we just don't know. So yes, there's evidence, particularly from wine-producing countries, so from Italy, from France, from Spain, from Argentina, that people can drink wine during pregnancy and they do not necessarily have a higher rate of fetal alcohol syndrome. But we don't know what other factors contribute to FAS, which is why we recommend just don't drink. You're pregnant, don't drink. Perinatal causes as well exist. So this is problems that happen during labor and delivery. If a child, as they are coming down the birth canal, are deprived of oxygen for too long, that can lead to intellectual disability. It's one of the reasons that we do monitor, the doctors monitor pregnant women so carefully during labor and delivery to make sure. And then postnatal also can be things like infections or head injuries. I often joke that the best time to get a traumatic brain injury is like really early on in life, because you've got enough neural connections to compensate. But don't really drop babies on their head, just to prove my point, because we could end up with intellectual disability, because you don't know specifically where they're going to land and what part of their brain is going to be affected, so it's best not to drop them. Don't shake them either. That's another no-no, okay? Those can lead to intellectual disability as well. And then we have some of our genetic causes, so Down syndrome, trisomy 21, extra chromosome on the 21st pair. And that's the one, of course, that we can screen for and do typically screen pregnant women for. There's also PKU, which is phenylketonuria, which is an inability to break down phenylalanine, which gets converted into tyrosine. PKU, children are screened pretty much at birth or within their first day. If they are found to have PKU, a modified diet is all that needs to happen. If they don't follow the modified diet, then there is a likelihood of intellectual disability developing. And finally, Fragile X syndrome, which affects men. Males have an X and a Y chromosome. Females have two X's, so if one X is fragile, the other one can compensate. Males don't have that same opportunity. So if they have that shaky little X with their Y, they oftentimes will develop intellectual disability. And that is the end of that.